thanks for having me. I appreciate it very much. As Gloria mentioned, I practice community pharmacy on nights and weekends, so I'm unabashedly a pro-pharmacist in community pharmacy. I lead the nationwide clinically network called CPSN USA. We're actually 3450 as of today. Our goal is to be number 3 by the end of the year, which would put us ahead of Walmart as far as number of locations as a clinically integrated network, single signature capacity. And importantly today, when my good friend Gloria connected with me, she had asked me to sort of kick off from the perspective of a pharmacoeconomist. Yes, that's a thing. A pharmacy economist with a policy background there's some training programs for that. And I thought that I would give you the world view, the high level view, and then I think all the speakers are going to touch all these issues we're about to talk about. So this is a lot. This is going to be about 20 minutes. Some of the slides are sequential, and there will be the panel, obviously, if we don't have time for questions. But really, the rest of the speakers are going to address pieces and parts of this agenda. So as a health economist, I like the global view, literally and figuratively. And I think it's worth reminding ourselves, if we already know, and understanding if we don't, that of course, the manufacturers, the pharmaceutical manufacturers are a punching bag. Some of that deserved, and some of it maybe not as much deserved. But when you look at us against other OECD countries, so think of that as the developed countries in the world, or the main developed countries in the world, that 193 number should stick out. So we spend about double what everybody else does on the healthcare system, and about $1,105 per capita on drugs, which is about 155% of average. Why is that important to see? Because it's important to understand that although we would all love pharmaceutical prices to be lower in this country and to spend less, and arguably we can always work on that and do better, as a percentage of the total bill, it's actually worse in some other countries, believe it or not. And we're not that far above average. And remember that we have inflated categories in other spaces, and I know two that Gloria has tried to tackle are hospital, 236%, and administrative kinds of functions that we're a little bit unique in the world. So keep that in mind, that it's actually, as a percentage against the rest of the world, it's these other categories that are even worse. Another phenomenon that's happened, Gloria and I went to school at roughly the same time. We've been in our career for a couple decades now. The biggest trend over that period of time was movement away from oral brands to oral generics, and then the rise of specialty. And there's no great definition for specialty other than high cost. Some of them are hard to handle. Some of them are not all that hard to handle. Some of them are fragile. Some of them are not. But they've become to be known as this narrow group of drugs that are just high cost. And so what's happened is, this is from 2019, and it's actually accelerated from here. Just to sort of close your eyes and think about these numbers. As we sit here in 2020, 2% of all fills will be 50% of the cost this year, specialty. 8% of all fills are brand, traditional. They represent about 30% of the costs. That means that 90% of all fills that we fill this year will be 20% of the cost. All right? Well, what does that mean as we think about trend year over year? This is a very, every year we end up having a chart that looks something like this over the last decade. So the change in unit cost for traditional drugs, even including brand, has gone down 6.4% year over year. Even in the face of utilization going up. So lower unit cost, utilization up, and even in the face of utilization up, net, less. Specialty, more. So it's getting sort of more amplified and more amplified over time. More fills are super cheap. At least they should be super cheap. Fewer and fewer fills are more and more part of the total drug spend. So we're seeing this bifurcation in the marketplace. This is my obligatory. I try to put this in every deck now. Again, I'm not going to full disclosure, I'm an unabashed proponent of community pharmacy. I think community pharmacy is at risk of going away. I think that infrastructure is essential. I think it's crazy because we don't spend that much money on pharmacy. Drugs are expensive, and really specialty drugs are expensive, but pharmacies are not. So this is drawn to scale. We spend $3.6 trillion in our healthcare system. And for those of you not budgeting in large numbers of zeros, that's 3.6 million millions, right? So the CARES Act is a 1.9 million millions. It's a lot of money, a lot of scale. And actually, this is IMS Health Data, IQVIA data, so they've got pretty good access to all the rebates. Post-rebate gross, 9.6. So we're spending 347 billion or 347,000 million on drugs, which is a lot of money, but in comparison to the whole, and that's how we treat diabetes, right? Number one cause of blindness, number one cause of chronic kidney disease, number one cause of lower leg amputation. And diet and exercise, we're trying to get there, but we treat it with drugs. And it's less than 10% of the whole. If you net out like the VA, the DOD, Medicare Part B, infusion, that sort of stuff, you get to a community pharmacy or retail gross of 6.7%. If you net out mail order, you get to 4.3%. So the gross, the entirety of claims, cash pay, everything out of a pharmacy is $156 billion. Pharmacy margins right now, net, are about 1.5 to 2.5%. Their gross margin is about 18 to 20%. So it's product in, product out. If you just look at that gross margin, what it takes to keep the lights on, have the building, make payroll, pay for the papers, pay for the IT systems, all of that, it's 20% of it. That's only $31.2 billion. So to keep 62,000 pharmacies electricity on and operating costs us less than 1% of the entire healthcare bill. In other words, you could wipe out every pharmacy in the country, and absent any substitution effect, you would only have about a month and a half to 2 months at most of healthcare savings across the entire system before you'd be right back where you started. So quit picking on community pharmacies, okay? Now, this disconnect, right? Spend half specialty, half regular or traditional medications. Except when we think about healthcare delivery, here's what it looks like in fills, the actual touch points with patients. Regular medications are still how we interact with patients in this country. And there's been some good studies now. Medicaid population, complex population, 35 times a year to the pharmacy, 3.5 times a year to the PCP. In Medicare, healthy Medicare, relatively healthy Medicare, you're looking at 9 versus 4, 5, 9 versus 6. So our main touch points are community pharmacies, and it's conventional medications still. So how did we get here from a PBM industry perspective? And I'd love to hear, I'm looking forward to the panel on this, because I take the sort of health economist, Harvard Business Review approach to things in my mind typically. So there was an administrative phase where it was just the profits were for being an adjudicator, right? Just pure administration. And it was really the pharmacies that were proponents of this because they didn't want to send in HCFA 1500 like things. And it's just administrative. So we created an online system to work between payers and the pharmacies. The first HIEs that ever existed, pharmacy, right? Then we had this generic conversion phase. So then PBMs made a lot of money on how do I go from Prilosec to omeprazole. Huge kind of windfalls for everybody involved except the pharmaceutical manufacturers. And you had really good alignment between the PBMs and the purchasers because you wanted to go, you say, hey, something was 80 bucks, now it's 20 bucks, or it's over the counter. I want to get everybody down to that. And so the PBM, the pharmacy, because they were making better margins on generics, and the purchaser were all aligned. But then what happened? Generic dispensing rate went up. When I first started, it was about 50%, then 55, 60, 65, 70, 80, 85, 90. In Medicaid programs, it's about 94% now, 90 everywhere else. Well, I can't make money that way anymore. I'm not converting from generic to brand. And then that's when rebates blew up, and this became the main, during the 2000s and the 2010s is when this became the main profit model because there was an alignment between the manufacturers and the PBMs to say we can't let people know how much the drug actually costs. And we need to engage in price discrimination. Now, I don't say price discrimination as a pejorative. There's other folks that do this, right? Convenience stores, airlines. Okay, if you fly business class, that's called price discrimination. If you book your ticket, right, 5-10 days out on Delta, you're going to pay more than if you book it 3 months ago. That's price discrimination, right? And so that's why you've got a different crowd when you fly Frontier or Southwest than when you're on a Delta flight. It's a lot of business people. I fly to DC all the time. All business people. If you buy your ticket 3 months before, $200. You buy it the day before, $1,500. So this is common practice to try to figure out how to charge people different things. But the only way you can really get away with that is the rebates. It all boils down to those rebates, right? Because I can't let people know what I'm actually paying. And then there's the spread phase. So then we said, hey, we've had enough of this. The federal government said, no more of this direct and indirect remuneration fees. We're going to squeeze the PBMs for those rebates so we know what they are. And then the PBMs basically said, well, we're not taking it. We're going to squeeze the community pharmacies. And so now what you pay the PBM quite often, or almost all instances, is more than what they're paying the pharmacy. So that's another way of getting spread out of the middle. And then now we're getting into the vertically integrated phase to sort of prepare for that jig being up. And you know what? I'm going to have my PBM as part of a large stack so I can channel everything in. I don't say any of this, again, pejoratively. This is straight MBA whiteboard stuff, right? But have you ever paid $20 for Starbucks coffee? Because that's the result, right? As an economist, I hate two things, right? Subsidies and lack of transparency, because those are two market killers, right? And so how is it that you would pay $20 for a Starbucks coffee? Because some of the price points aren't all that different than 90% of fills out there. Coffee is actually really, really, really cheap, right? And to make it's actually really, really, really cheap. But if you want fancy coffee, you know, semi-fancy coffee, you might go to Starbucks or a local barista. If you want meds dispensed safely, you should probably pay more than 65 cents a fill, right? It's kind of hard to get a professional to actually do stuff safely. But the actual cost of the coffee itself and is not that expensive, just like pharmacy's not that expensive, right? So how do we end up paying $20? So at the producer side, right, we've got this at the bottom, and then we've got this 223 so that we can make money as Starbucks and we can be sustainable and have, you know, I don't know how many millions of Starbucks there are in the country, right? But then in healthcare, we had this kind of $2 to $17 or even sometimes more administration cost associated with it. Again, for 90% of fills, but sometimes it's even egregious in the brands and the specialty. So as economists do, they can take very kind of disparate data sets, make some assumptions, but they're pretty sophisticated at a macro level. Health Affairs, as many of you know, is a very, very reputable journal. If any of you have had to go through peer review at Health Affairs, very extensive process. This was a fascinating study that came out, and the data is relatively old. So all of these things on the left-hand side have actually been amplified because, again, every time something goes branded generic, it puts pressure on how do I continue this money train on the left-hand side. But what you're looking at is, hey, it costs us this much to manufacture on the left. We sell it above cost so that we can pay for, you know, different types of things and make a profit. Great. Hey, I'm happy that Moderna and Pfizer and J&J are successful vaccine makers, aren't you? Right? And profits are fine. It's just we need transparency, right? And even the manufacturers are calling for it. Then you've got a wholesaler, you got to distribute it. There's some take out of there. And then this number's dropped substantially over the last decade, getting down into 12, 10, 8, 6 in some instances, and then below cost in some instances, which leads to lawsuits oftentimes that violate state law. But that's very, very generous. Almost any pharmacy would take that right now, as I think folks on the call that are panelists will say. But that's what you're doing to sort of get it, you know, as a total cost of it out to folks safely, and hopefully you can add some services to that, right? And then we have these rebates that go, that's this $24 to kind of administer it and figure out how to do spreadsheet wars, right? For every $100 worth of cost. So that's a bigger view of it here. And I would love to see them do an updated version of this, because I think some of the numbers, the first 3 columns have changed pretty substantially. And then, of course, the list price of these drugs has gone up. But as we've seen with insulin, that doesn't mean the net to the manufacturer has gone up. So put another way, put more simply, drawn to scale for 2021. Again, these numbers that I talked about earlier, this is what it looks like. So cost on the right, patient touch points on the left. Huge disconnect, right? What does that mean for our healthcare system at large and our delivery system? So now we're going to get a little bit detailed, a little bit wonkish. My apologies. But I try to sort of, and there's more complexity to this, as many of you know, but in a more simplified way, say, hey, if you think about purchase, pharmacy purchase, what the PBM is doing and what the purchaser is doing, let's think about this in the different phases as we look through over time what the business models have evolved. And you see in the administration phase, just kind of a simple administration fee, right? And then you've got the generics phase where you've got alignment. Then we introduce the rebate phase where, wait a second, we don't really know what's being charged to whom. And actually there's wholesaler rebates too. That is something that's now relevant. That wasn't in Gloria's initial slide. And again, as the rebate transparency battle revs up, we get into spread. And so I had the opportunity to work with Chris Schaffner, who runs the community care plan in North Carolina as a level funded plan. So he gets employer data. Employers said, yeah, please look at my data. Help me understand this better. We had access to actual wholesaler data because there was a large wholesaler in North Carolina, and what the pharmacies did actually pay for it. And we were seeing 30 to 40% spread for employers less than 500 employees across the entire book, including specialty. And then also we were seeing 15 to 25% for employers on average above 500 employees. So you're getting a little bit better deal. A lot of times there's more of a staff on the employer side to look at this. Oftentimes it's employers like health systems that have pharmacists and other staff that kind of know, so they can kind of keep things a little bit more honest, and they're being subject to spread. But basically this kind of concept here is you paid 20 bucks for the Starbucks, the pharmacy got $5, then 4.5, then 4, et cetera, except you don't know what it costs at the Starbucks in these models that sort of get at this. And this is why, Gloria brought up GoodRx and discount cards, because if so much of the market you're actually paying more through the insurance, not only the employer, but oftentimes even the patient, and then that patient copay was being collected and going to the PBM, where the pharmacies are saying, you're making me charge them 10 bucks and I'm willing to sell it for $8. And so what emerged then were these discount cards, because there was a layer then that said, wait, I can match buyers and sellers. And if it's cheaper than using your insurance and it's a better deal to the employers potentially. Now there's some data selling and stuff that goes on that's going to need to be worked out on some of these folks, but it's becoming a competitive marketplace. Even to the point where the PBMs have one in-house, which is a fascinating development from my perspective. Again, I don't say that pejoratively, but it's like, you're offering this, do it through the insurance, right? And there's reasons, valid and rational reasons for that, but it should tell you how kind of messed up the marketplace is, right? So reference-based pricing, if you've been sort of battling hospital pricing, and I've heard through some birdies that in Indiana it's a topic, what's the equivalent to Medicare fee-for-service or reference-based pricing in the pharmacy world? Well, the closest thing is NADAC, and I would encourage you to get in the deck, and this is a pretty good kind of nonpartisan third party. They talk about some of the things where it's not necessarily actually what the pharmacy paid, but but it sort of walks you through what NADAC is, where it came from, and why it's worth looking at, why it's becoming more and more popular as a way of setting up contracting with the purchasers, because the idea is to try to get the cost plus in a ubiquitous way. And so, you can look at your contracts, for instance, and say, oh, well, my contract says we're going to pay pharmacies AWP minus 85, and I'm getting a much better deal because it was AWP minus 82. And you go, wait a second. NADAC is 92% or 90. That's even better. Well, doesn't that make the pharmacies upset? No, not often, because they're actually getting paid more with NADAC, and that's because of that spread, right? falls apart a little bit as you get closer to brand and specialty, because you do need those rebates. That's the sort of addiction that employers and plans and others have, and that's the way they kind of hold you in on those rebates. But it's transparent, it's published. You can go on to the website, and there it is. You can do your own updates. You can keep your own NADAC file. We keep our own NADAC file at CPSN, and more PBMs are moving to a NADAC model as a way of disrupting the marketplace. So the basic kind of way that it works is pharmacy paid X for the drug. Sponsor pays pharmacy Y for the drug if you're a self-funded plan. And then there's this big discounted off AWP, but when there's no spread, it's basically saying, you know what the pharmacy paid for it, and I can actually have this, say, $8.50 a dispensing fee. In Medicaid world, these run from about $8.50 to, I think, $10.50 is what I've seen, and then sometimes there's quality bonuses associated with that. So it kind of puts everything on par, right? So again, the difference, it's a better benchmark. So otherwise, you have no idea what you're actually paying for that coffee, right? Both on materials, but then whoever put that coffee together and says, well, this is what we're being paid, and it's $5, right? So imagine if Visa or MasterCard charged you a $17 transaction fee on a cup of coffee. That would never happen. Why? Because one, the producer, the retailer, knows what they're charging the customer, and they know what they're being charged. And the problem with kind of rebates and spread is that the parties don't know, neither the party knows the whole part of the equation, right? Just like you've been dealing with hospital pricing. And hospital super bills are the equivalent of AWP in pharmacy, ain't what's paid, right? So, and it's a way of sort of creating networks how you want to see them as a payer. So you can do this. We do this analysis for folks a lot. I'm sure Mark will talk about TrueRx and others that will do this analysis for you, but you can do it with your own internal. You don't even need to share your data. You say, I'm self-funded, give me my pharmacy claims. I'm going to compare it against NADAC, and I'm going to see what you paid or we paid you versus what the pharmacy would have got if we were a NADAC plus 850 model, let's say. Because remember that 90% of the drugs are generic, but there's a list of about 300 to 400 drugs that are penny drugs, like coffee, basic coffee. I get a jar of 1,000 of them for, $5 type of thing. So part of what we try to do on our side is say, look, there's 62,000 pharmacies out there. There's mail order. The problem is everyone's got roughly the same way of contracting, the same kind of formulas across a particular plan sponsor. And so you could do really well, good haircut, bad haircut, same reimbursement. And it started in the sort of adherence space in the Medicare program where, the pharmacy doesn't get a bonus, they actually get a penalty, which is kind of a weird concept, because if you say, well, we're not actually increasing reimbursement, we're just going to penalize you if you have a small PDC. But as Gloria was pointing out, that doesn't mean anything about the optimization of medications. And if I'm a purchaser, what I care about is blood pressure, A1C, hospitalizations, patient quality of life, and those types of things, right? Whether they filled their meds every month is kind of less consequential than what's their health and how is it improving their health with the main modality that we have to improve health, drugs, right? So moving this from this kind of retail spread business to a service-based business is what I work on every day. Hey, 35,000 pharmacies. I got 3,500 pharmacies that if they could get out of buy and sell and say, I don't even want to buy and sell. You do that employer, you do that PBM, you negotiate and whatever else. Just give me a service fee and then hold me accountable for outcomes. They'd sign up in a heartbeat because there's just not much there on buy sell. I showed it to you in the numbers, right? They're not retailers anymore. They have to be service providers and charge a service fee, not sell shampoo, perform haircuts, right? Get paid that way. So again, if you look at the spend versus the touches, right? You got a lot of mail order that's out there, but then you have 1 billion face-to-face opportunities with a patient wasted if you don't figure out a way to work with pharmacies differently. And a lot of plans and a lot of the public's come around to sort of understanding this as we've gotten into COVID testing and now as we get into vaccinations. They're thinking about pharmacies differently, like, why wouldn't I just ask the pharmacy to figure out how to reduce A1C? It is pharmacy. They know a thing or two about drugs. They're coached. They can coach, right? And the landscape's rapidly changing, I'll tell you, out there. There's actually a marketplace, an outcomes marketplace emerging, a real one in pharmacy. The problem, though, is that they do something really well, but they get paid to do this other thing, put pills in bottles, safely, right person, right drug, right bottle, stuff that pharmacists have been complaining about for 30 years. So we got to start paying them for hitting outcomes, just like we started to ask primary care, do something differently, we'll pay you differently for outcomes. There was never a MACRA, a MIPS, an ARA, a high-tech of this kind for pharmacy, unfortunately, and that needs to happen. Because the pharmacy benefit's supposed to be the thing that reduces the other side, except we don't have any contracting or vehicles, though those are emerging now, that say, wait a second, we've got this big divide. Pharmacy is supposed to make us more healthy, so we spend less on total cost of care, except we don't have any contracting vehicles or incentive vehicles that cross the river. Except we do now. These are actual contracts that we have in place, and we've had over 75 contracts, and we've only failed on one of them to hit our performance measures. Diabetes, we're going to pay you a per member per month for patients that are greater than 9. And we're going to either withhold that or pay you less if you don't submit an A1C as a pharmacy, and you don't reduce that A1C as part of a care plan. And care plans are now becoming ubiquitous in pharmacies, where you can collect and share drug therapy problems, vitals, labs, plan of care, oftentimes now social determinants of health, and then screenings like PHQ-9 depression screenings. Here's another one. We'll do a modest $10 PMPM, and we're going to do a large shared savings to the pharmacies for making sure that these folks don't end up in the ED. We got an asthma ED problem. This is for pharmacies. Why not? Just to give you a sense of one set of results for a Medicaid MCO, that third one is blood pressure control in the HEDIS measures. 100%. How many providers get to 100% blood pressure control in patients? They can do it. They've just never been incentivized to do it at scale and in a meaningfully contracted way. Here's another one published. A1C. When these practices were in quality-based initiatives, didn't have a pharmacist they were working with closely in the community and the pharmacy, 72%. When they did, 94% of patients less than 9. You just have to get them on the team, right? And then also, even stuff that you wouldn't think is necessarily pharmacy. Mammograms. Again, the equivalent of the US population is in a pharmacy once a week. What a better place to screen folks and say, hey, you need to get something. And they trust them. I'll close with this. This is the most recent pharmacy quality services. I'm on the board of Pharmacy Quality Alliance that is the sort of nation's premier organization for pharmacy measures, sort of a sister to, say, National Quality Forum. Think that, for pharmacy. And they're the ones that publish the Medicare star ratings or put together the formulas. If community pharmacies could submit evidence of biometric test results, blood pressure, diabetes, this is surveying plans. And if you're a self-funded plan, you've got control over this, right? Would you be willing to contract on outcomes? Yeah. Over 2/3 of the plans, which is pretty remarkable. So we're seeing a sea change in how we pay pharmacies and how we pay for drugs. And as self-funded employers in particular, you have the opportunity to innovate if you've got folks that want to innovate. So I don't know if we have time for questions. Hopefully, Sarah and Gloria, they didn't go too long. I had timed it about 20 minutes, 25 minutes. And I can do questions now, or hopefully that kicks off the rest of the panel.